first session today is Ethical Considerations Impacting the Disability Community During Emergencies. I am quite happy to introduce our keynote speaker, who, as you just learned, acts as the director of the Institute for Ethics and Public Affairs at San Diego State University, where he also serves as Associate Professor of Philosophy. Welcome, Dr. Stramanda. Please feel free when you're ready to begin with a brief physical description of yourself.
Thank you so much, Mark. People can feel free to call me Joe if they'd like. I'm not really big on titles. And I am very proud to consider myself part of the disability community, having both disabilities that I was born with and those that I have acquired throughout my 40 some odd years. I am a white man with a dark beard and sparse dark hair. And I'm wearing a black t-shirt and my background is blurred. I would also like to say that I am coming from San Diego, where I work and live, and it is Kumeyaay land that I reside upon, that has been colonized. Okay, so I'm going to start by sharing my screen as the basis for my talk here. If I can figure out how to, yeah, there we go. Okay, so the main title here of the talk is Ethical Considerations Impacting the Disability Community During Emergencies. Power, Vulnerability, and Institutionalization in the Time of Pandemic is sort of the subtitle, because of course there's lots of ethical considerations that impact the disability community during emergencies. And so what I thought would be most useful would be to talk a little bit in general about disability ethics or disability healthcare ethics, and then narrow it down into a particular case or context or application of some of these methods and ideas for thinking about what we ought to do in emergency situations. So I'm going to start off by talking a little bit about my methodology. I come to this work, as I'd already mentioned, as a disabled person myself. And so I am really interested in sort of the viewpoint or the perspective of disability, or I should say perspectives of disabled people when they think about and consider ethics in general, because I think it is an important perspective that has many times been ignored or lost in a lot of the conversations that are had, both in academia, in the scholarly journals and things like this, but then also in public policy debates and in politics. And so I want to just sort of highlight the fact that what I'm up to, what I'm interested in doing, is what's called disability bioethics, and it very closely aligns with the disability rights slogan, "Nothing about us without us," but applied to the field of ethics. Okay, and so Jackie Leach Scully wrote a really important book in the early 2000s that's called Disability Bioethics: Moral Bodies, Moral Difference. And in it, she draws this distinction between the ethics of disability and disability ethics. I think that's really crucial to what I'm up to. And so I'm just going to quote really quickly from her book because I think it's illuminating. "The ethics of disability is the systematic reflection on morally correct ways to behave toward disabled people in everyday interactions, in healthcare, in employment policy, or in law. By disability ethics, on the other hand, I refer to the particular moral understandings that are generated through the experience of impairment." And so what she's saying here is the ethics of disability is when you take sort of ethical systems or ethical principles that have been largely developed by non-disabled people, and you apply them to the contexts of disability through healthcare, law, so on and so forth, right? Whereas disability ethics is kind of the reverse. Instead of taking sort of ethical systems that have been sort of already built throughout history by non-disabled people, disability ethics tries to think about disability as a perspective or a point of view that can produce ethical theorizing, okay? And we might not even realize that we're sort of producing ethical theorizing, right? But Scully argues that we are, that as disabled people and as folks that work closely with disabled people, when we make arguments from the experiences of disability, we're developing new ways and new systems of thinking about morality. And so I want to try to do this with you all today in respect to questions around emergency preparedness, okay? And so here are sort of some of the starting point questions that we might ask about emergency preparedness and disability ethics, okay? First, how can the experiences of disability inform what emergency preparedness policy should look like, okay? And so looking at sort of the everyday lived experience of disabled people, and then the experience that we have in crisis situations can really change how we think about what emergency preparedness policy should look like. And when we center those experiences, we're doing disability ethics, okay? How can the experiences of disability help identify what even counts as emergency preparedness policy, okay? And so really, we can think about disability ethics and this shift in perspective as pretty radical. The intervention that I'm going to talk about today as a form of emergency preparedness policy usually isn't even thought of as emergency preparedness policy. It's thought of as something else, right? As maybe a disability rights issue, or maybe as a healthcare issue, okay? It's not thought of as emergency preparedness policy. And so I want to suggest that shifting our perspective to take up the point of view of disabled people can redefine what we even think counts as emergency preparedness policy. And I'm sure you've heard a lot of that this week, honestly. I don't think I'm really saying anything that new, being on the last day here, right? But perhaps I'm giving some new language or some new conceptual framework that you can use when thinking about it. And then finally, this I think is really the key to the topic that I'm going to take up with this methodology of disability ethics. How does political power determine if or how disabled people can influence their own response to an emergency situation? So, in other words, human agency, our ability to act in the world, and the ability to determine our own fate isn't equal in our society, right? Different people have more or less power to be able to determine how their life goes, right? This is true for people of color. This is true for people in the queer community. This is true for women. And it's certainly true for disabled people and folks that occupy the intersection of all of these different marginalized positions and groups, okay? And so if that's the case, then we need to think about how it is this unequal distribution of power can determine a disabled person's own ability to act and to help themselves or protect themselves in an emergency situation. And so that's what I'm kind of going to be talking about today when thinking about disability ethics and emergency preparedness policy. So the specific problem I'm going to be trying to apply all of this thinking to is the vulnerability of disabled or elderly people in long-term care institutions during COVID-19. Okay. So it seems like a million years ago, but it wasn't that long ago, right? Early March of 2020, when all of this COVID-19 coronavirus stuff started impacting our lives in very big ways. A nursing home in Kirkland, Washington, home of Costco, one of my favorite stores, called Life Care Center, became an early epicenter of the COVID-19 outbreak. In other words, it was one of the first places in the United States where COVID appeared and began to spread rapidly. Okay. 2/3 of all the residents in this nursing home became infected, and about 1/4 of those died from the disease. Okay. So it was the Life Care Center and places like this that really triggered a lot of the emergency response that we saw, the shelter in place orders, and so on, because it was apparent that this disease was very infectious and spread very, very easily, and was very deadly and killed a high percentage of the people that were infected with it. Okay. And so this didn't stop, though, with the shelter in place orders, right? This high rate of infection and death in long-term care facilities and institutions didn't slow down when the emergency preparedness policies were triggered and put into place, right? We saw nursing home outbreaks across the country throughout 2020, and really throughout the pandemic, even through Omicron and so on and so forth, okay? And so nursing home outbreaks really were, unfortunately, widely cited only as evidence of how elderly and disabled people are more physiologically vulnerable to the disease, right? And I want to argue that mainstream bioethics is ill-equipped to do so because it's not doing disability bioethics. It's not centering the lived experiences of the people actually living in those places, okay? It lacks adequate moral analysis of institutional long-term care in general, because it's not centering the lived experience of the residents, okay? And so to understand the duties that a society has to those in institutional long-term care, we have to reconceptualize the meaning of the concepts of both vulnerability, like what it means to be vulnerable, and institutionalization, or what counts as an institution. We have to rethink these basic concepts. And we have to do so in a way that centers or accounts for the experiences of disabled people that are actually at risk of being harmed by diseases and other problems like the COVID-19 pandemic. Okay. And so I want to argue that vulnerability should not just be defined in terms of physiology. Okay. Certainly someone can be more or less vulnerable to a disease because of their physiology, but they can also be more or less vulnerable to disease because of the power that they have or that they lack. Okay. And so vulnerability is also a matter of power. Secondly, I want to suggest that institutionalization should not be defined in terms of the traditional uh, conceptions of it, right? Usually, when we think about what counts as an institution, whether it's in public policy or even in the popular imagination, we think about institutions as being tied to particular places, right? Particular kinds of buildings or ways that people are segregated from others in an institution, or the size of the or the amount of people living together, right? And so what I want to suggest is that institutions, instead of thinking about size and place and so on and so forth, we should think about power and say that power is, at the end of the day, what defines whether or not something is or is not an institution. And that will help us think about why people are vulnerable in certain places rather than others to infectious disease. So just to recap a little bit, there are some standardly accepted interventions from that protect people from infectious disease in institutional long-term care that we saw pop up when the COVID-19 pandemic first came on the scene. And to illustrate that, I have a classic. Now, everyone is probably familiar with a graphic like this of an N95 mask, right? What counts as your N95 mask? And so we have a picture of a non-medical mask that has a little valve on the front of it, and it's white with yellow straps, and then a medical N95 that is blue with white stripes with no valve. And a little amount of text at the bottom says this valve lets germs escape and points to the non-medical version of the mask. Okay. And so the standardly accepted interventions included improved staffing ratios, better staff training and infection control practices, better enforcement of infection control protocols, more and better access to PPE for staff like N95s, more access to rapid testing for residents and staff, okay? And so I want to suggest that while these were important and good things to do in sort of a non-ideal situation to try to protect people, they were very, very, very inadequate because we weren't thinking about the ways in which people can be vulnerable to a disease like COVID-19 in ways that are nothing to do with physiology, okay? And so I want to suggest here that standard duties to protect and standard interventions to protect too narrowly define vulnerability, okay? Vulnerability is not only about the biology of the virus and the biology of the human body, okay? It's not only about how easily someone catches the virus as opposed to someone else or some other kind of virus, or how sick it makes you or how deadly it is for a particular person because of the makeup of the virus or the makeup of that person's body, okay? Yes, it's true that the virus does affect different people with different bodies differently, but focusing only on this explanation of vulnerability to bad health outcomes really obscures the ways in which power plays a role in creating vulnerability to infectious disease, okay? And so a philosopher by the name of Shelley Tremaine was one of the first to point this out early in 2020 when she was thinking about why in Canada the nursing homes had this high rate of infection and death as opposed to the general population. And so I'm going to quote from her blog where she talks about this topic, and she says, "Deaths have been cast as tragic consequence of the unique circumstances that surround the virus itself, attributed to its specific features and etiology, the speed and efficiency with which it circulates, the lack of epistemic authority about it, rather than attributed to and regarded as a consequence of the very nature and functioning of the nursing homes in which the deaths have occurred. Seniors and elders in nursing homes and elsewhere aren't inherently vulnerable, nor are disabled people in institutions inherently vulnerable. Both of these groups, among others, are rendered vulnerable. That is, they are made vulnerable And here she's talking about being made vulnerable or rendered vulnerable by power disparities, by differences in power to control our own lives when we are living in an institutional setting. Okay. And so if vulnerability is a power disparity, then we need to rethink um, our basic concepts about how disease operates within the disability community. Okay. And so here I have another picture. Some of you, this is a pretty famous one, actually. Some of you might recognize it. It is a photograph from Willowbrook State School in New York, where our hosts are residing. And it is a photo of a number of children that present with different races and genders, and presumably they all have some kind of disability. I think I see a few that look like they probably have Down syndrome, and they're all very, very crowded into a crib that they can't move around in, which is in, it looks like perhaps a hallway in a very sort of medical looking uh, dormitory building at Willowbrook State School, sort of the classic institution. Okay. And so I want to say that vulnerability, whether we're talking about vulnerability to a virus or whether we're talking about vulnerability to abuse and neglect, um, is something that is not inherent to a disabled person. We aren't sort of vulnerable because of the bodies or the minds that we have, but we're made vulnerable by the way power is unequally distributed within our society. Okay. And so people talk about health disparities and the social determinants of health that track race, income, gender, and so on. And they talk about how power creates these disparities in health all the time. Bioethicists and public health officials are all about the social determinants of health, right? Unfortunately, a lot of times, disability isn't included in these discussions of health disparities and the social determinants of health because it's assumed that any disparity that we see in the disability community or any um, amount of disease that is present within the population of disabled people is there not because of power, but because of our physiology. It's just sort of assumed that, well, of course they're more vulnerable to getting sick. Just look at them, right? They're using wheelchairs and walkers, and they're using ventilators, and they're obviously very medically fragile people. So of course they're going to get sick and die more often than these robust, healthy, non-disabled folks. This can't have anything to do with power disparity. And so what I want to say is that health disparity and power disparity are deeply connected, not only for differences like race, income, gender, and so on, but also for differences like disability. And one of the ways we can put a finer point on that and sort of argue for it as true is by looking at how the COVID-19 virus spread in institutions and thinking about it as a matter of power disparity. Okay. And so we need an analysis of how power disparities embedded in the long-term care system have made people vulnerable to infectious disease like COVID-19. So I'm going to start off with institutions as they are sort of typically defined, okay? Both in public policy, right? But then also in what I would want to call the public imagination, right? When we talk about institutions in our narratives, okay? When we talk about them around the dinner table, when we talk about them in op-eds, in newspapers, even when we talk about them at adapt actions and in protests, okay? A lot of times when we say institution, we're talking about one of three things that makes something an institution, okay? The physical size of the building, the numerical size of the number of people that live together, or the segregation or integration of the community, okay? We say that these are the things that matter to whether or not something counts as an institution, okay? And I want to argue against any one of these actually mattering, okay? So first, physical size, right? The physical size of the dwelling in which people are housed has sometimes been thought of as sort of what makes something an institution, right? So in my past life, before I was a stuffy academic in at a university, I actually worked for a protection and advocacy agency. I am a proud alumnus of Disability Rights Texas, where I served on the State Supported Living Center team and went into the state schools in West Texas to monitor them for neglect and abuse. Okay. And so one of the really interesting things that I learned while I was there is that some of these state schools thought that, well, they could become something other than an institution. They could become a non-institution, right? If they just changed the size of the building that people were living in, okay? And so instead of having these enormous sort of dormitory style buildings where lots and lots of disabled people lived in one physical building, it was thought we could create these cottages, right? These smaller buildings that are clustered together on a campus. And it would make it deinstitutional or less institutional, okay? That didn't work out, right? It became really clear that, you can change the size of the building, but people are still very much institutionalized, right? The state schools, even if you have sort of small cottages that people are living together in, they're still institutions. And so then folks said, well, maybe it's not the size of the building, right? But maybe it's the number of people that are living together, right? And so let's take these cottages and let's sprinkle them out into the community, right? Let's take, let's buy up houses where you'll have just, maybe 5 or 6 disabled people living together in a house. And that won't be an institution, surely, because the number of people on a single campus will be very small, right? Just 5 or 6 people on one piece of property rather than a few hundred, right? And so this is where we saw sort of group homes emerge as an alternative to an institution. And guess what? Group homes were hit with the pandemic virus almost as hard as nursing homes and state schools. Okay. There's even literature coming out of New York that showed this, right? And so then people have started thinking more recently that, well, it's not really the number of people that live together in one home or one space, right? But rather it's how integrated they are into the community, right? Whether they live together with non-disabled people, maybe in the same house or apartment building or neighborhood. And so what we want to do is try to integrate rather than segregate as much as we can. And then we'll finally have deinstitutionalized people, right? They'll be in the community, okay? I want to suggest that not even this is the thing that makes something an institution, right? We're getting closer, right? It probably matters more than something like the physical size of the building or the numerical size of the number of people that live together. But even segregation versus integration isn't really the key. It's not really the thing that makes something an institution or not. For that, I want to say we need to talk about burritos. We want to talk about institutions defined via power disparities. Okay. And so notice that at the beginning of the talk, I wanted to suggest that this concept analysis that I'm going to be doing, this way of rethinking the basic ideas that we use when we think about infection control, what it means to be vulnerable, what it means to be an institution, that these ideas were going to be informed by the lives of disabled people. Well, one of the ways I'm trying to do that is by thinking about what's called the burrito test. Okay. So here is a picture of a number, I don't know, like 12 or 14 frozen burritos. These are vegan, just I don't want to offend anybody in the audience, I guess. And so we'll have some vegan steakless ranchero burrito, veggie samosa, and so on. These are wraps and burritos laid out on a wooden table for our consideration here. Okay, and so hopefully why I have a bunch of burritos will become clear in a moment in my slide. So I want to say that institutions are defined fundamentally. The thing that makes a thing an institution is the power dynamic within it, right? Or more importantly, the power disparity. Okay. And so, according to my view, an institution is any place with any number of people, okay, where a disabled person lives in which they do not have control over the care and support they receive. Okay. So, on this view, there can be an institution of one where someone lives in their own house or their own apartment. Okay. And so it's not in sort of a big building, and it's not with sort of a bunch of other people, and it's not, segregated. Okay. It's integrated into a neighborhood or into an apartment building with lots of non-disabled people. Okay. But they still can be living in an institution if they lack meaningful control over their care. If they lack the ability to control how their care is provided. Okay. And so this means that they lack the power to determine what care they receive, right? What they need help with or don't, where care is received, like where they live, right? When care is received, this one's often overlooked, right? Having someone tell you when you eat your meals, when you bathe, when you get dressed, right? And most importantly, I think, who provides that care, okay? And the reason why I think who provides care is the most important feature of this power disparity. This is the thing that someone really needs to be able to control in order to not be in an institution. There's two reasons, right? One reason is that helping with many activities of daily living entails a kind of physical intimacy that really needs to be a choice, right? Who touches you should be a choice. That's the definition of assault, right? And worse crimes, even other things, right? If you agree to have someone touch you, then it's a hug. If you don't agree to have someone touch you, then it's assault, right? And so determining who it is that provides this care, I think, is super important because of the intimate nature of personal care that disabled folks need with things like dressing, bathing, and so on, bathrooming, okay? But also I want to suggest that the power over the other features of care, the what, the where, and the when, sort of flows from the power someone has or doesn't have over the who of providing their care, right? This is simply because if you have power over who is providing your care, if they're not doing it right, right? If they're not allowing you choice over what care to receive or where it's received, or when it's received, right? You can fire them and hire somebody else, another who, right? So giving a person control over the who also gives them implicit control over these other features of care, because they can tell that person what to do, right? In caring for them, okay? And so this sounds pretty complicated, but it's really not, right? It's really not. One way to think about it is what folks in the disability community, and especially in the developmental disability self-advocacy community, refer to sometimes as the burrito test, okay? And this is something a lot of folks will probably already be familiar with, hopefully. My friend Cal Montgomery, who has both physical and developmental disabilities, first sort of told me about the burrito test. And basically, the idea here is that no matter where you live, if you live in your own home, if you live in an institution that's traditionally defined, like a state school or something, or in a group home, right? The question to ask of do you really live in an institution? The question that you want to ask is, can you decide in the middle of the night that you're hungry and want a microwavable frozen burrito, right? Or you can, replace that with anything else, right? You can replace that with, I don't know, frozen pizza, right? Or even a trip to the 24-hour diner, going to the IHOP. Some people call it the IHOP test. Can I go to IHOP in the middle of the night, right? If you can do that without someone else telling you no, right? This isn't the time scheduled for you to eat. This isn't the time scheduled for you to go out, for you to get out of bed, for you to do X, Y, and Z, right? If you can do that without somebody else controlling that choice, then you pass the burrito test and you don't live in an institution, okay? If you can't, then the chances are the power disparity exists that would make whatever arrangement you're living in count as an institution, according to my view, okay? So community-based care is a lot of times what people talk about in the disability rights movement, okay? And I want to say that community-based care, what we really mean when we say community-based care is a certain kind of power relation, right? This power relation that I'm talking about, power over who, what, where, and when you receive care, okay? So here's a photo of some famous disabled folks. I don't know the person on the right. If anybody knows who the person on the far right is, please let me know. But I do know that on the left, we have Ed Roberts and Judy Heumann, who are largely considered some of the first people to come up with the idea of community-based care and independent living. They started the first independent living center in my current home state of California. And I believe that this photo is taken at the first sill, but I'm not sure. It's a black and white photo from the 70s, probably. Ed is on the left in a power chair with his ventilator, and he has a mustache. And Judy is in the middle, also in a power chair, in a sweater vest and a long sleeve dress shirt and some pearls and glasses. And then there's another person on the far right in a turtleneck sweater. So community, I want to say, or what we think about as consumer-directed care is not where someone lives or what kind of building it is, or so on and so forth. It's really just self-determination of the what, the where, the when, and the who care is provided, okay? And so I want to suggest, philosophers love thought experiments, right? Sometimes thought experiments can get really weird, right? And so I try to have thought experiments that are really believable, right? that aren't, about like how many angels can dance in the head of a pin or something ridiculous, right? And so for today, I'm going to suggest that we have a thought experiment here, right? To show that community-based care can exist in a large building that is largely segregated with only disabled people living there, and that includes numerous disabled people, lots of us living in one place, and it still be community-based rather than institution-based care, as long as the right kind of power relationship exists, as long as the disabled people living there control the what, where, when, and who of their care. Then it should be considered community-based care, okay? And so for my thought experiment, we have a large university dormitory where lots of disabled people live together in a sort of self-segregated situation. They chose to live together. They determined the where that their care is received. And they share personal care attendants, maybe other college students, right? That come in and provide help with housekeeping and dressing and bathing and laundry and so on and so forth. And they direct their own care. They get to decide which person they hire to do X, Y, and Z, right? And by the way, it passes the hell out of the burrito test, right? Not only can you go to IHOP in the middle of the night if you want to, heck, you can get your PA to drive the wheelchair accessible band to the bar, right? And do what college students do, okay? Here's a spoiler. This isn't really a thought experiment. This is a real life example. This is how I went to school, right? I lived in a giant land grant university college dormitory at Michigan State University, where a bunch of us cripples got together and took over one of the floors on the dorm, right? And we all lived together. We all segregated ourselves. We all shared personal attendance, right? It was not an institution, my friends, because we had the control over the what, where, when, and who, okay? So what does this have to do with infectious disease? Social distancing. So one of the most effective measures for preventing infection is social distancing. We know that now, right? Here's a graphic that sort of makes up the background of this slide. It has a label of 6 feet and then a bunch of dots that are supposed to probably, I don't know if they're supposed to represent, spit droplets or maybe the virus itself. And there's 2 figures, one person sort of looking like they're probably like sneezing and the other person just sort of standing there saying, what the hell, why are you sneezing on me? And an arrow that says 6 feet, right? Okay, so we know that one of the most effective measures for preventing infectious disease is what we call social distancing, right? But social distancing doesn't mean that a person must physically isolate themselves from everyone, right? We're social animals, right? All the way back in Aristotle, they talked about, human beings being social animals. We need each other to survive. We cannot live in isolation from each other for very long, okay? I have 2 small kids, right? A almost 7-year-old and almost 5-year-old. But at the beginning of the pandemic, they were like real little, right? I think they were like 2 and 4, right? And so social distancing was, not a thing for them, right? We couldn't isolate them, right? I couldn't just, lock my grubby little 2-year-old in a closet somewhere until the pandemic was over, right? He was climbing on me and licking me and doing all the weird things that little kids do to their parents, right? Um, so social distancing, honestly, was not about isolating yourself from everyone, okay? What social distancing is carefully choosing who you are in close proximity with, okay? I decided that it made a lot of sense for me to be in close proximity with my 2-year-old, even though he was a big time infection risk, right? But the way I handled that was by none of us being in close proximity with other people, right? We created our own little family pod, right? Where we got our groceries delivered. We really didn't go anywhere without masks. We didn't really go anywhere at all for the first few months, right? Because of this thing about social distancing, we took control over who we associated with, okay? And so what I want to suggest is that institutional care, by definition, takes away a person's control over who they are in physical proximity with. So it makes this strategy of infection control probably the most important strategy of infection control during the early days of the pandemic, right? It took that away from disabled people. That lack of power is what caused the ridiculously high infection and death rates within the disability community, right? The practice of social distancing becomes impossible, not because people need care of an intimate kind, right? My 2-year-old needed care of an intimate kind too, right? But because unjust power disparities kept them from determining who was providing that care and how, okay? They couldn't decide to social distance, right? They had to be having others decide who they lived with and what risks those other people were taking. They didn't have any say over it, okay? And so that's what created this level of incredibly high vulnerability, okay? So here's my last slide. It turns out, that people receiving institutional care are made vulnerable to the virus because of the very nature of what counts as institutional care, the power disparity, okay? So the moral analysis of institutional care in general, I think, has then revealed something important about our moral obligations during an emergency situation, right? We have, as a society, an obligation to give people control over their care during an emergency situation, whether it's something like a viral pandemic or something else, right? Self-determination is the key to not being institutionalized, and it makes you less vulnerable in all sorts of ways. I highlighted how it made you less vulnerable to infectious disease today, but there's all sorts of ways not being institutionalized makes you less vulnerable to emergency risks, okay? And so our duty to disabled people during the pandemic turns out to be the same really as any other time. Provide them with community-based supports and services that are centered on and that are defined by their own capacity to determine what kind of life they want to lead with what kind of care and who provides that care. So that's my talk for today. Hopefully we have some time, at least a little bit, to discuss. I'll leave this slide up for just a second. It includes my email address if anybody wants to contact me, jstramondo@sdsu.edu. I'm happy to continue the conversation. And I will stop sharing.
Thank you so much, Joe. Can you hear me, Mark, at this point?
Yeah.
So much to think about. Real quickly, but very importantly, because you put the word out there and it shows you how close attention everybody was paying. The mystery person in the photo has been identified by lots of our attendees as Joan Leon of the World Institute on World Disability.
Joan Leon. Can somebody put in chat or somewhere? Is it already in there? Yes, it's already how to spell it. Okay, got it.
All right, so that's good for you to know.
Yeah, it's super important. Thank you.
I did have there are actually no questions in the chat right now, but I've been interested. I wanted to ask you this. There has been, we've had several interesting conversations that obviously intersect with yours, although yours has been very unique and very eye-opening. There, folks in the disability community are referred to sometimes as context providers as we head toward demanding inclusion of people with disabilities in all emergency preparedness planning. I was interested to know whether that phrase is familiar to you and how you would respond to it in the context of your view of the, the agency that really needs to be required here.
Yeah, context. I'm not familiar with that term, but I can sort of appreciate it. I think that context is important because everybody is going to have a different context with that they're coming at an emergency situation from, and so policies should be, I think, flexible enough to account for these different contexts. And I think that a big part of my talk was a way of arguing for taking into consideration an individual's individual's knowledge about their own context, and making sure that that applies to whatever response is offered. And so I'm sympathetic to it. I guess I'm a little worried maybe that it's too weak of an idea, right? Where it's like, if all they are is context providers, that means that we have this big, policy that we're going to just sort of plunk down on all people. The only thing we really need from disabled people is a few of the details about the context, right? And so that might
Context of
be a
what you
little,
said today, yeah, I can
yeah,
understand.
yeah. And
what
so
you're
that's a little
saying.
bit worrisome, but if we include context, if we understand context in like a broad way, rather than like a real narrow way, then I think that's a great term. That seems really promising.
Okay, interesting. And one of our attendees, who is a longtime advocate, has posed, I'm wondering if the difference between outcomes between people in institutional care versus consumer-directed care during COVID has basically what he's saying, has it really been studied yet? So that there is data that you can use to support some of the thoughts that you're putting forward. And I'm interested in knowing your thoughts about the necessity for study and data on these issues.
Yeah. No, that is super important. I am not an epidemiologist or a social scientist. I'm an ethicist, right? And so I don't conduct those kinds of studies. But if those studies do exist, I would want to know about them. So if anybody knows about them, email me.
Okay.
But that would be super supportive to the argument that I'm trying to make here. Having that data would be like so cool. So yeah, I really should try to, I wrote this paper a while back, before, that kind of data really was available.
Right.
And so, I think, thank you for the reminder that I really should go back and sort of try to see if some more research has been done on the different outcomes.
Well, it's a reminder to everybody in attendance that we need to be demanding that, I think. So we've got like 1 minute left. Is there any final message that you'd like to send to folks before we send them off for their veggie burrito break?
Excellent. No, I mean, I guess the only thing I'd like to say is thank you. Thank you for putting together this awesome conference. I think it's so critical. I really appreciate you inviting me to come and be in conversation with you here. If anybody wants to reach out, for any reason, to talk more about any of these topics, or think that I am missing something in my approach, please feel free to shoot me an email. So thank you so much, everyone.
Thank you very much, Joe, and to everybody who attended. Please join us for session 2, a great group discussion. It will begin at 2:30. We will now be taking a 30-minute break.
Enjoy your veggie burritos, everybody.